Good morning, everyone. Thanks for being here. Kind of a small but mighty crowd. You never know based on the volume in this room how many people were actually in here. That's excellent. So thanks for being here. Thanks for your energy, for your enthusiasm. We have a great presentation planned for you this morning, but we have a little bit of modification that I'll tell you about in a moment. But we will start with a reflection. Colleen found this one for us. She always finds great reflections, and I think this is a good reminder for all of us. It's titled, Because the Patient. Because the patient has a need, we have a job to do. Because the patient has a choice, we must be the better choice. Because the patient has sensibilities, we must be considerate. Because the patient has an urgency, we must be quick. Because the patient is unique, we must be flexible. Because the patient has high expectations, we must excel. Because the patient has influence, we have the hope of more patients. Because of the patient, we exist. So I don't work with patients every day, so this is a great reminder of why we're here doing what we do. It's very important work, so thank you all for your efforts and for your work in this area, and healthcare in general. So, getting to my introduction here, our change in plan is, as many of you know, I hope you were not all here expecting breakfast, because that's the plan, part of the plan that has changed. Mike is out sick today, so we won't be having a cooking demo. So Janae is here still for questions and things when we get to that point, but Dr. El-Shahat will modify the presentation a little bit. So no cooking demo today, unfortunately, but we understand that that happens. So before I do introduce our presenter for this morning, I wanted to mention last month we had on the comment form, somebody asked about why don't we do more to talk about some of the benefits that employees have available to them within as members of Aviation Healthcare. And so that's not really the purpose of this forum, but I will mention this morning that all of that information is available to you on what would have been Vital Signs is now the intranet under the Human Resources tab. There is a lot of information there, things like the Thelma membership and other benefits such as that. So if you have any questions on it, you can call me, but it is all under the intranet, that's on the intranet under the HR tab. All right, now, did you know that approximately 84 million American adults, that's 1 out of 3 of us, are pre-diabetic? That's a pretty significant number. And I'm pleased today that Dr. El-Shahat is doing his part to help reduce that number. And Dr. El-Shahat is a family medicine provider here with us in the Fond du Lac Regional Clinic. Actually started out as a hospitalist, but made that transition not too long ago. We're very grateful to have him with us. In fact, as I was walking into the session this morning, I was talking with one of his patients who just was singing your praises. So you should know that people appreciate having you here, as do I. But Janae is here, as I mentioned. Janae is our registered dietitian, so she'll be able to add to the conversation as well from a what do I really need to eat standpoint to be healthy. So with that, if you could join me in welcoming Dr. El-Shahat.
Thank you. Everyone can hear me okay? All right. First of all, good morning, and thank you for giving me the opportunity to come up here and speak to you about diabetes and pre-diabetes. I think this is a pretty interesting topic, so let's go ahead and get started. So, being a primary care physician, I think my primary directive a lot of the time is disease prevention. And so I think this, rather than concentrating on treating diabetes, we're going to spend much of this lecture kind of talking about how do you prevent diabetes or reverse the diagnosis of diabetes or pre-diabetes if that's what you end up with. So this is a conversation, much of this slide shows a conversation that I have with all my patients who come in with either hyperglycemia, which is high blood sugar, or pre-diabetes, or even a newly diagnosed diabetes. This is much of this is kind of the conversation I have with them. And it's geared toward understanding the mechanics of how diabetes comes about, understanding the definitions that we're dealing with, because really, if we're going to beat a disease in submission, you have to kind of understand it. You have to understand how it works, all the aspects of it, and you want to boil that down as much as you can so that you can get the heart of the issue and address it. So, first of all, what is prediabetes? Prediabetes is kind of a wake-up call if you're on the path to diabetes. It's a shot across the bow, if you like, and it's an opportunity, I think, to really take a close look at some of the behaviors and habits that we have, and an opportunity to reverse those so that we don't end up in the diabetic range. Like Holly had said, about 86 million other Americans have prediabetes, and all it means is that the blood sugars are higher than they should be, but not quite yet in the diabetic range. All right, this is an interesting factoid. I didn't know we had access to this information. It's a little scary, if you ask me, but about 22% of Magnesian employees that participated out of the 2,900 that participated in the HRA last year were diagnosed as pre-diabetic. That's about 640, if you think about it. That's actually a good chunk. And roughly 70% of people who are diagnosed with prediabetes do go on to develop diabetes. So definitely something worth addressing and worth turning around. So what is diabetes? Diabetes is a group of disorders in which there are high blood sugar levels. And then these blood sugar levels, if left alone for too long, can cause all sorts of complications, both short and long term. Given that it's a group of disorders, that means there's more than one. There are type 1 and type 2 diabetes. This talk is focused on type 2 diabetes because type 1 diabetes is a genetic autoimmune condition, and prevention doesn't play as big a role in that condition as it does in type 2 diabetes. Though some of the information would definitely be useful for type 1 diabetic as well. This is an interesting little guy right here. This is the international symbol for diabetes. And I didn't know that there was one, but there is, and it's a blue circle. And I think, if I read it correctly, it's supposed to stand for the circle being unity and blue being something to do with the sky. And yeah, I don't know how they come up with that, but it is what it is. All right, some more interesting factoids. I think sometimes we assume that diabetes is a new thing, something that modern medicine has taught us about. In fact, as it turns out, the human race has been struggling to understand and treat diabetes for over 3,500 years. Looks like one of the earliest descriptions of in written history of diabetes goes all the way back to circa 1500 BC. In ancient Egypt. I don't think that is actually about diabetes. That's just an interesting cartouche. But they described it as having too much urine, which we'll go on to talk about as being one of the cardinal signs of diabetes. The ancient Indians have a very old culture as well, also noticed that the patient's urine would attract ants. And so they called it honey urine. And we think that they were referring to diabetes, and that's pretty accurate too. We'll talk about why that happens too. But not until the 1560s AD did the words diabetes mellitus come about, and that was coined by Aratus, I'm going to butcher it, the Cappadocian, I think is how you say that, physician of Alexandria. It sounds very Greek. Diabetes mellitus roughly translates to sweet urine. The direct translation is something along the lines of sweet siphon, which I think also means sweet urine. Statistics, because these are more neat factoids. Prevalence, as of 2015, roughly 30 million Americans had diabetes. That's about 9% of the population, quite a big chunk there. 1.25 million of those are children. And adults who have type 1 diabetes. So definitely the vast majority type 2 diabetes. Undiagnosed, of the 30 million, 23 million were diagnosed, and about 7 million were not diagnosed diabetics. About 1.5 million Americans are diagnosed with diabetes every year. And in 2015, 84 million Americans aged 18 or older had pre-diabetes. And think about that. 70% of those, if you think about an earlier factoid, will still move on to have diabetes. So you can see this is a problem that's being compounded, not figured out. As far as deaths go, diabetes remains the 7th leading cause of death in the United States in 2015. And I think that will go up. All right. Diabetes is a disease that spans all races. There is definitely some prevalence in African Americans, Native Americans, and Alaskan natives. There's one subgroup here that isn't mentioned, which I think pertains to us quite a bit. That's the Hmong population. So the Hmong population actually has a very high prevalence of diabetes as well. I worked with an academic physician who was studying the Hmong population up in northern Wisconsin, and he believed that the prevalence of diabetes in the Hmong population was as high as 30% or even more. And there's a lot of theories on why that is, but that's, I mean, pretty big numbers if you think about it. I mean, 3 out of 10 with diabetes, that's huge. All right. So costs, put it in dollar signs. $327 billion a year in total cost of diagnosed diabetes. About $237 billion of those are medical costs for various complications and medications. $90 billion of that is in lost productivity. So, yeah, lots of money. Signs and symptoms. So these are what I think are the cardinal signs of diabetes. There's more, but these are the ones that really, if I hear a patient complaining of these, diabetes really, alarm bells start going off in my mind. Urinating more often, increased thirst, increased hunger, fatigue, blurry vision, and slower healing time for cuts and bruises. Now, fatigue is probably by far the #1 reason I screen a patient for diabetes. Someone comes to me and says, I have unexplained fatigue, I have changed nothing in my life, and I'm suddenly fatigued. Diabetes is high on the list of things that I want to screen for. Slower healing time for cuts and bruises, that factors in big time for people considering surgery or any kind of intervention. So these signs and symptoms are important to keep an eye out for. So how do we diagnose diabetes? Fasting blood sugars are the quick and dirty method. That is the fastest and the cheapest method of diagnosing diabetes. A fasting blood glucose of higher than 126 is enough for a diagnosis of diabetes. And pre-diabetes is a fasting blood glucose of 100 to 125. I can tell you my fasting blood glucose on my last biometric screen was 90, so that's not that far off. So that's scary stuff to think about how easily it is to hover into that range. Anything at random blood glucose over 200 is enough for diagnosis of diabetes, and pre-diabetes for random blood glucoses that falls between 140 and 199. A1C is the gold standard for diagnosis of diabetes, and an A1C of 6.5 or higher is enough for diabetes. Pre-diabetic has an A1C typically in the 5.7 to 6.4 range. All right, so now we go down to the mechanics. What exactly is going on? I think we assume too easily that when you tell a patient that they have diabetes, that they understand, okay, my blood sugar's high, but really, I find in my practice that no one really understands why this is happening or how you transition from being non-diabetic, pre-diabetic, diabetic. What is this thing that you suddenly diagnosed me with? So this is typically the conversation I have. When you eat food, your body needs to turn that food into energy, right? So it breaks food down to the simplest sugar molecule, or one of the simplest sugar molecules that your body can then use, and that's glucose. And that's done through a complicated digestive process. Glucose then goes from the gut into the bloodstream and kind of hangs out there. It's ready energy to be picked up by all the stuff that uses energy. That's muscles, all your organs, everything that uses glucose, which is everything. So to get from the bloodstream to the places where it needs to go, there has to be some kind of process there. There has to be some kind of signal that says, hey, there's sugar in blood ready to be picked up, okay? That's the role that insulin plays. So there's an organ that sits behind the stomach, that's this guy here, the pancreas, that secretes a hormone called insulin, and that insulin is the marker molecule. That's the one that tells the body, hey, there's sugar here ready to be picked up. Let's go ahead and do that. All right. The higher the longer there's sugar in the blood, and the higher the level of sugar, the more insulin there is, and the higher the level of insulin. Over time, if there is just too much sugar in the blood, or it stays there for too long, the tissues that respond most to insulin become resistant to insulin. Okay, the example I like to use is something like a mosquito bite, right? So you get bit by a mosquito, it's just like, that's all you can think about. And a couple hours later, that goes away, right? You don't feel the itch as much. And it's not an exact example, but you get the idea. The signal is just there for too long, and the body just becomes resistant to it. And that's actually the medical name for type 2 diabetes, insulin resistance syndrome. So people who have diabetes or prediabetes are more predisposed to things like heart disease, strokes, dementia as far as brain goes, blindness, and chronic kidney disease. High levels of glucose are also directly toxic to nerves, and so that's why diabetics develop diabetic neuropathy, tingling, numbness, chronic pain. So how do I prevent diabetes? And interestingly, how do you reverse prediabetes? It falls into the same category. So the most sensitive, and actually that's a somewhat incorrect statement, the most sensitive tissue to insulin is actually brain tissue. The second most sensitive tissue is muscle tissue. But brain tissue, I mean, once you reach a certain part isn't growing. The point in life is not going to grow anymore for most people. But muscle tissue still has the opportunity to grow, and so that's the one we're going to address. So the most important aspect of diabetes prevention is diet and exercise. You want to really increase your muscle tissue and sensitize the muscle tissue to insulin. And the way you're going to do that is by building up your muscle mass. The more muscle you have and the more active your muscles are, the more glucose the muscles need, and so the more sensitive to insulin they are. And so that's probably one of the most important aspects to preventing diabetes. How big of a role does genetics play? Because I get this a lot. This idea that, oh, my parents have diabetes, so there's a guarantee that I'm going to have diabetes. Not so much. If I see someone who's tall, I assume that their parents are tall, and if I find out that their parents are short, it's not like a mind-blowing situation. Oh, okay, they're short. So while genetics certainly plays a role, it's not a guarantee by any means. But there is definitely a predisposition there. And all that means to me is there's an opportunity here to control the things you can control to prevent the genetic aspect from getting the better of you. So the things that you can change are your habits, obviously. Best way to increase muscle mass? Do what this guy's doing. Don't do that much, though. It's really uncomfortable. But the point here is weightlifting exercises. Aerobic exercise is a great way to go, but study after study shows that weightlifting is really the way to go. It doesn't have to be Olympic level competitive weightlifting. It could be something really basic, but again, the idea here is you want to really build up that muscle mass. You want to really strength train. So that kind of level of exercise is what we're talking about here. All right, avoiding prediabetes, eat healthy, exercise, maintain a healthy weight. That's how we avoid getting into the scenario altogether, and kind of just reinforcing the same idea here. Risk factors. So we talked about some of the things you can't change. These are some of the risks that might predispose you. And again, like I said, to me, this is knowing these risk factors is just one more thing to say, okay, you have this predisposition, time to start addressing the other aspects of your life that you can control so that you don't cross over into the pre-diabetic or diabetic range. So risk factors are being overweight, being 45 or older, middle-aged or older, having siblings or direct family members with type 2 diabetes, physically active less than 3 times a week. Me, right? How many of us are actually physically active 3 times a week? It's hard to do. And physically active is a relative term, right? So to me, that means being actually like lifting weights, aerobic exercise of some kind. To the patient who has trouble with that, physically active can mean something like walking a dog. That's enough activity, but it has to be something, right? And then gestational diabetes. That's a tough topic. So gestational diabetes is high blood sugar while pregnant. Now, that doesn't always, when we see that, that doesn't reflect a diabetes outside of pregnancy, but it can certainly predispose it. So it's another one of those risk factors. All right. Now, here is a really interesting topic, and that's glycemic index. So we'll talk about that in a second here, but how to reverse prediabetes. You want to limit your large blasts of sugar, right? Why? Because those large blasts of sugar are those things that are giving that really large blast of insulin. The insulin really hangs out in the bloodstream for a long time. Again, building up this resistance to insulin that we don't want. One of the worst culprits for me in my practice, carbonated beverages. Soda is just the worst. And I think it has something to do with how accessible those sugars are and just how much there are. I think, and you guys don't quote me, but I think it's something like 80 grams of sugar in each can, which is just insane. It's a huge amount of sugar. And people who drink carbonated beverages regularly rarely ever just have one. It's several a day, and a lot of times with a meal, so you're compounding the amount of sugar that you're getting. It's just the worst. Carbonated beverages are terrible. You want another thing you want to do is decrease the amount of easily accessible carbohydrates. To me, I mean, carbs are carbs. So bread, rice, pasta, everything that everyone likes. You just want to decrease the amount. Whenever I mention that to a patient, the response is invariably all the good stuff, right? So you're telling me I can't have all the good stuff. No, not so much. It's more along the lines of you want to decrease the amount of the good stuff and maybe decrease the number of times that you're eating them, right? So does having diabetes or prediabetes mean you can never eat pasta? No, of course not. What it means is that you probably can't have pasta 4 times a week, right? You really just need to portion control the amount of pasta as well. I like to tell my patients, and this varies from physician to physician, to keep their total carbohydrate intake under 150 grams a day. That means very little, right? So I tell you to keep your carbohydrate intake under 150 grams a day. How many grams of carbs are in anything? Who knows, right? So I like to put it into terms that people can actually relate to. 1 slice of bread, white, wheat, multigrain, it makes 0 difference. They all have the same number of carbs. It's roughly 45 grams. So you can see how that number really adds up quickly, right? You have your 1 sandwich a day, that's 100 grams, assuming you're just talking about the bread. You throw in everything else, and you're already probably close to your limit, right? So really paying close attention. If you are at risk, if you have these risk factors, if you are in the pre-diabetic range, or you're getting close to it, really paying close attention and label reading is really the best way you're going to avoid this danger, okay? The other thing that you want to do is you want to spread that out. You don't want to have your 150 gram allotment all at once, again, because you're trying to limit that large blast, right? So you want to spread that out over the day. Now, that's really tough to do. 150 grams over the entirety of the day, tough to do. But nothing that's worth doing is easy, right? So this is something worth doing. All right. So glycemic index, let's talk quickly about that. That is a really under-talked about topic. So glycemic index is this idea that we can measure how quickly after a meal, and depending on the type of food, your blood sugar spikes. Okay? So foods with a high glycemic index, those are your carbonated beverages, sweets, whatever, easily accessible sugars, result in this large blast of blood sugar very quickly. And this is timed down here, and this is your blood glucose level. So you get this huge blast of blood sugar within what looks like 10 10 minutes to half an hour. But the problem is what goes up must come down, right? And if you go up this fast, you're going to come down just as fast. Really the blood sugars only stay up for this very limited amount of time. The problem is once you get down here, guess what kicks in? Your hunger mechanism, right? Your blood sugar drops, and now you're hungry. You're hungry within an hour, right? So that whatever it is that you've just had that has caused this large blast in sugar now has completely worn off and left you ravenous, okay? That's a problem, right? Why? Because you've just had a huge blast of sugar, you're gonna go and have another huge blast of sugar, right? So this kind of compounds the issue, okay? What you want is this. You want this low glycemic index foods. You want foods that are going to cause a slow rise in blood sugar and then a nice slow dip so that they kind of last longer. The idea being you end up staying fuller for longer. Okay. Now I've mentioned some of the carbs that have a low glycemic index. Your oatmeal, your sweet potato, your legumes, those are your beans. Those are great ways to go. Some of the stuff that's not on here are the stuff that's becoming really popular nowadays. If you go into grocery stores and you look at those ancient grains, you know, quinoa, and I'm not sure if that's the way you say that word, and farro, and all these other really interesting grains. And yes, they're a little odd and a little out there, but really, there's a reason why the ancient peoples used these grains. That's because they kept them fuller for longer, and a small amount would do that. And so I think that is a topic that is absolutely worth, if you're talking about what foods can you start to integrate and play around with so that you can prevent these large blasts, I think addressing this is a great way to go. Any Google search will tell you, give you plenty of examples on low glycemic index foods, but that is a great way to go. I've personally tried incorporating sweet potato instead of my starches. I think it works great. You know, I think it's just a matter of actually doing it, and once you get used to it, super easy, super easy. I don't even miss regular potatoes. I find it works much better. All right, you get plenty of exercise. You know, we said that a couple times, and that's super important to do. All right, that's all I've got for you. I'd like to kind of open the floor to questions. I know that's a kind of a lot of information, and a lot of it was kind of simple and boiled down. So if you do have any more detailed questions, please don't hesitate to ask or to have. Yes?
Increased water intake, is that of any benefit?
Yes, absolutely, it is. So increasing your water intake will help in a couple different ways. It helps, first of all, with digestion, and second of all, will help you get fuller quicker, right? So you increase your fluid intake, and you may be taking less of your, if you're looking at your table setting, whatever's on your plate, right? You drink more water, you get fuller quicker, you don't need to have as much food. I think that that's a great way to, a great method to incorporate. But I don't think it's an answer in and of itself. Why? Because there's no nutritional value outside in the water itself. So if you just drink a huge amount of water and have a small, I don't know, whatever, Snickers bar, you're just gonna have the same issue, and you're gonna get hungry again much sooner than you'd like. So while important to incorporate, by itself, not a plan. Right? Okay. Good question.
What's the theory behind the increase in the monk population?
So, if I remember right, I think it's something to do with how recently they've been exposed to our culture. So, before they were brought to the United States during the Vietnam War, the Hmong populations, those in Southeast Asia, like Laos and those types of countries, were pretty remote, not really exposed to our culture of plenty. Much more eating food when it becomes available kind of an approach. So you move them into this culture where you can eat whatever you want, whenever you want, all the time, and the genetics that play a role in how they're able to handle that, they just don't have those. And I actually think that's part of the reason why, outside of socioeconomic status, why Alaskan natives, Inuit culture is also high on the list, because again, that's a relatively, compared to the rest of the world, recent exposure to this culture of plenty, this idea that you can have food anytime, and as much as you want. I think that's part of the reason why. And also the change in food, right? So going from, I think the sweetest thing that they had was probably fruit, right? And now moving to, well, I have access to soda and sweets and all this other stuff, like easy sugars, also probably, the genetic producers just can't handle it. Good question. Other questions? Yes?
What about the keto diet?
Keto diet. All right. So I am not a huge fan of fad diets. Okay, not because there's not science involved. There is. Keto diet is one of those that has a lot of really good science behind it. My problem with fad diets is how long you can keep it up. Okay, because this isn't a one-time battle. This is a war. This is a marathon, right? This is not a race. So you want to be able to find a method of dieting that you can keep using for the entirety of your life, right? Keto diet, and if I understand it correctly, involves eating essentially only protein, really cutting out carbs altogether or minimizing them as much as you can. And while that's well and good, how many people do you know that are going to be able to say, I'm never going to eat pasta? It's just not, it's just not something that you can keep up, right? The idea is good, the science is good, right? You eat more protein, you eat less carbs. Proteins are, incidentally, one of those foods that keep you fuller for much longer, right? So what I tell people is, if you're going to decrease your carb, or if you're looking at your plate, you want to decrease the number of carbs, but you want to increase the protein content. And again, the idea being you want to keep yourself fuller for longer. But to eat protein alone, I find that really tough to do. I know I would have a lot hard time doing it. I don't think I could, but maybe as a stepping stone to a longer diet solution, I think keto is a great way to go. If you want to use it to lose a lot of weight fast, and then know that the plan is always to move to a diet that you could use long term, then it's fine. But to have that be your only solution to the weight problem, to your pre-diabetes problem, I don't see that being something you can sustain. At least not in my experience. So. Yes?
What is the downfall of diet soda? Some people say, oh, we're not going to have regular soda, we're going to have diet soda. But that's not good for you either. What is the downside of that?
Very good question. Diet soda, I can't say for sure why there's a downfall there. I know that it is, if you're doing a head-to-head, it is better than having regular soda because it doesn't have the sugar. Diet soda, I heard this theory on it from an endocrinologist, and I don't know if it holds true, but it kind of makes sense if you think about it. So, diet soda tastes sweet, and it has because it has artificial sweeteners in it. The way artificial sweeteners work is they are sugars that your body cannot digest. Your body can't access those sugars. Okay, you drink this the soda that your body thinks is sweet and is expecting a sugar blast. You don't get that sugar blast, and so what happens is your hunger mechanism gets triggered, and then you eat much more of whatever else you're eating, right? So I don't know if that's true. Like I said, it kind of makes sense, but I thought it was an interesting theory. But like I said, I think at the end of the day, if you were to ask me, is diet soda as bad as regular soda? No, outside of whatever artificial sweeteners the dangers involved are. Is it the best thing is to have no soda at all, right?
Thank you.
Yeah. Yes?
Can you talk about the effects of binge drinking and the metabolism of alcohol? For that.
I had an interesting conversation with a patient the other day. She told me that she was told that hard liquor has no sugars or carbs in it. And exactly, right? That was my response, right? I was like, that can't be true. What? I looked it up. There are no sugars or carbs in hard liquor, right? So vodka, rum, whiskey, scotch, there's no sugars or carbs. There are some downsides. Rarely, I think, do you binge drink. I mean, outside of the person who has a drinking problem, do people naturally binge drink and drink alcohol alone? First of all, usually, if you're talking about mixed drinks, you run into the same problem with large blasts of sugar, huge amounts of sugar in mixed drinks, and then the other thing is hard liquors will actually drop your blood sugars. Okay, so if you were to check the blood sugar of a patient right after they, I don't know, took a shot of vodka, their blood sugar would actually drop. I won't get into the mechanics of why that happens, but it does. And I suspect part of the reason that you're going to fall into problems is as that blood sugar drops, once again, you're going to activate that hunger mechanism. You're going to get hungry. I mean, not that it's ever happened to me, but if you go out drinking, you tend to eat really bad food, right? And you tend to eat a lot of it, right? So that's part of the problem there. So is binge drinking in and of itself going to raise your blood sugars? No. Everything that goes along with it, absolutely. And you can certainly, and that's not even touching upon the problems with drinking, with alcohol and alcohol use itself, which are many and numerous, and is a discussion in and of itself. So, all right, good question. Other thoughts? Questions? Yes?
When you limit your carbs, say you're doing Atkins and you're focusing on more protein, but you're getting lower, but then like Atkins, they have you increase them. When you're in that low period, sometimes they'll have you run like 20 grams of carbs. Is that bad, like how your body processes more of the protein? Like you focus on vegetables and protein, like big things of salad, whatever vegetables. So does that give up any toxins with just how your body processes that, you know, brain-wise, like it's not healthy? I know various like nurses, they're so smart and they do it, it works for them. And they go to hard liquor too. But with diet soda.
So my issue with Atkins is the same as my issue with all fat diets. Again, not something sustainable. Is it dangerous in and of itself? No. You got to remember, you got to understand, go back to understand why, you have to kind of understand where we came from. The origins of the human race are, and the way we eat are thought to be, you know, we're hunter-gatherers, right? Our bodies are used to eating protein, you know, whatever, twice a week, and are eating nuts and berries and vegetables for the rest of the time, and eating infrequently and irregularly. Do I think that there is a danger to eating protein every day, all day? Yes. Is it going to be something measurable immediately? Probably not. Again, I just don't see Atkins as something sustainable because you're going to cheat. You're going to. It's not something that I think can be done indefinitely. And so whatever dangers are involved are immediately alleviated as soon as you stop doing Atkins. So that's just kind of my thoughts on that. Yes?
So my question would be, like, in your practice, how do you engage those people that are pre-diabetic or just found out they were diabetic? You know, because some people I can see saying pre-diabetes, or, you know, is it a thyroid problem, or not taking ownership of what they're doing, you know? of
Yeah.
their diet and exercise and
And-
engaging them.
That goes back to that conversation about, you know, how big a role does all the other stuff play. I'm sometimes to my detriment a little straightforward with my patients and honest, because I think it does them a disservice if you're not. I'll tell them that yes, genetics plays a role. Yes, all your risk factors play a role, but they are not a guarantee. And no, as I said, they are an opportunity to take control of things that can be controlled. Putting it into those terms, I think, for me, helps the patient understand that there is a role for them as well. It's not just, this is something that's guaranteed to happen to me, or this is something as a result of whatever else, other disease process I have. I had a patient tell me that she was started on a medication and then developed diabetes right after that, and she felt that it was a medication side effect. While some medications can cause weight gain and blood sugar rises, they in and of themselves will not cause diabetes, right? It's that lack of activity, that worsening diet, that's going to be the culprit here. And so that making that transition point clear, making them aware that yes, there's stuff that puts them at risk, but that transition, that crossing over point, tends to have a lot to do with habits and what you're doing, and that is the point that you want to push further away from. So, all right. Other questions? All right, great. All right. Well, thank you all very much. I really appreciate it, and hopefully this was helpful. And I think I'm going to turn it back to Holly.
Thank you.
All right, so fill out your green slips if you're interested in what do we have today, Carrie? Chance to win.
We have a lot of miscellaneous military stuff. Hoping we were going to have a cooking demo, hence the expandable measuring cups. But they're still pretty handy.